Hi. So we're just waiting for some guests to arrive and other people. So if you allow just a few minutes, and when we're ready, I'll just ask everyone to mute themselves. Good morning, everyone. So I think we're ready to start. We have quite a few people here. I want to welcome to our Diagnostic Cytopathology webinar. I'm sorry if this camera is a little bit awkward. My name is Paula Almeida. I'm a biomedical scientist at Manchester University Nhs Foundation Trust in Diagnostic Cytopathology. And I'll be your host today. So any questions, I'll be looking at my phone. Don't think it's strange. It's just on this TV, I can't see your questions. And today we have an amazing panel of guests. We have Rosvina Zafat. She's a lead BMS. And we have Dr. Shelton is our clinical lead for cytopathology. And we have Simon Bailey that he didn't join yet. Am I correct, Rose?
Yes, I think he's not joined yet, but he's at clinic, so he said he will join.
Exactly. So Dr. Bailey is our MFT Oxford Road lung cancer lead. So you have like a huge panel that you can ask many questions, whatever your career pathway that you're looking for. You can ask us anything. So I'll give the word to Rose and she'll do a presentation. Thank you very much and enjoy.
Okay, good morning, everyone. My name's Rosvina Zafar. Please call me Rose. I'm the lead biomedical scientist at in non-gynae cytology at Manchester NHS Foundation Trust at the Oxford Road site. And I'm just going to talk to you a little bit about how to become a BMS, what we actually do in diagnostic cytopathology, what does a BMS do, and then the career pathway for a BMS. So to start off with how to become a BMS, everyone will need a portfolio, and there's various routes to becoming a BMS, but the main thing is that everyone has to have an IBMS registration portfolio, And once you have got that, then you have to register with the HCPC Council as a biomedical scientist. So the various routes that a person can go through to become a BMS, the first one is an apprenticeship degree in biomedical science. Several universities are offering this. We've got a member of staff that's currently a medical laboratory assistant at a band 3 who's currently going through this process. So he has 1 day off study leave to attend university and write up any assignments that he has. And through this degree apprenticeship, it's all funded through the trust. And as long as the department can allow for the study leave, then the member of staff can go via this route. Part of this route, the university will provide the registration portfolio, so the in-house training will be provided by the department. And at the end of this apprenticeship degree, it's usually 3 years, the member of staff will have a registration portfolio completed and be able to register with the HCPC and then eventually apply for a biomedical science job as a band 5, which is great news, and we're all for promoting and progressing our own internal candidates in their career pathway. The next way to become a BMS is for a student to, after completing their A-levels, is to go to university and do an accredited IBMS biomedical science degree. This is usually a 3-year course, but sometimes can be 4 years where the student will take 1 year out and go to a placement and complete their portfolio. And then year 3, they'll go back to university and complete their following academic studies. If, however, you have someone that has done a degree, for example, in chemistry, like I did, and I wanted to become a BMS, I contacted the IBMS to ask if I could become a biomedical scientist. However, my degree wasn't in biomedical science, it wasn't accredited. So I had to submit my modules to the IBMS. They had a look and they said all I needed to do was some top-up modules. So this still applies now, where if a member of staff or a prospective person would like to become a BMS and they haven't got the accredited degree, they need to approach the IBMS, submit their degree modules. The IBMS will verify what they need to do, and most likely what happens is that you'll have to do a top-up modules, which usually takes about a year, part-time, usually done in an evening, and at the end of that your degree is then accredited for you to then apply for a registration portfolio. So that's a route that I took. I did a top-up course, a PGC, which is a postgrad certificate in biomedical science. I did that, and I then did my registration portfolio, and then I became a BMS, registered BMS with the HCPC Council. So they're the 3 basic routes to go through. And moving on, so what do we do actually in diagnostic cytopathology? So as I'm sure everyone knows, that cytology is a study of cells, and it's basically from fluid samples taken from anywhere in the body to diagnose disease. The samples are mainly unfixed, so we need to process them within 24 hours. And this is what we do at MFT, that most of our samples, our 7-day turnaround time is 97%. Which is excellent, and our 10-day turnaround time is around about 99%. So we don't use any automation in cytopathology at the Manchester Foundation Trust. Everything is done by the BMS, and where cells are transferred from the fluid sample onto a microscope slide and analysed using a microscope. So what does a BMS do on a day-to-day job? So we process samples in a category 3 laboratory, and we work very closely with our pathologists that are in the department. Over 50% of our work involves the BMS attending clinics that are on-site as well as off-site. And the off-site sites are Trafford General Hospital and the Christie Cancer Hospital. They're both quite local to us, around about half an hour bus journey. So a biomedical scientist attends clinics there. These clinics are BMS adequacy assessment clinics where the BMS are all trained to provide adequacy assessment for all fine needle aspirations, which is excellent service that we provide to our users. On a day-to-day job for the BMS, it's quite varied. They can either be doing a category 3 processing work, or they can be off-site attending clinics, as well as being on-site attending clinics providing adequacy assessment. Anyone travelling off-site is usually a band 6 or above. We don't do any weekend work currently. It all depends on our users. So as soon as the users start taking samples on the weekend or providing a 24/7 service, we will have to change according to that. The cytology samples that we have can be used for ancillary and molecular testing, which is also great news for our users. Rather than taking biopsies from patients, we're actually taking fluid samples that we can get a cytology preparation from that, and also go back to the residual material and prepare any immunohistochemistry that we require, or any molecular testing that we would require to personalize the medicine for the patient. Moving on to the career pathway for a BMS, there are two pathways. Either a BMS can go into management, or they can go into becoming a consultant BMS. To go into management, and this is what I have done, is that progressing from a band 5 up to a band 8, there are several things that you can do. You can do an MSc in biomedical science, as well as approaching the IBMS and doing a certificate of expert practice. Now, the certificate of expert practice are in 3 categories. They do a quality management certificate, they do a training certificate, and they also do a leadership certificate. And once you've done that, that just gives you a little bit more knowledge into the management side of becoming a BMS. And once you've done those and you've got your MSc, and if there is a job opportunity available of a band 7 or above, staff may be able to apply for those jobs and hopefully be successful. Following a band 7 position, it's always advised to do a leadership course. So what I've done the Nhs Leadership Course in Mary Seacole, which was it took about a year to do, where you attend study days, and you have to do it's like an essay, a 1,500-word essay, which gets marked and assessed, and you have to pass that. However, if you don't want to go into management and you prefer to go into the more diagnostic side, you can become a consultant BMS, where you have to, once you've done the registration portfolio, you can do your specialist portfolio. Once you've done your specialist portfolio in the discipline that you want, which will be cytopathology, then you go on to the higher specialist portfolio, which is a bit more niche. It's non-gynecological higher specialist portfolio. And once you've achieved that, you can go on to do the diploma of higher specialist in non-gynae cytology, and that allows you to report negative exfoliative samples as well as malignant exfoliative samples. And that is the career pathway for a BMS, going from a band 5 up to a band 8 and above. It's either through the management pathway or the consultant BMS pathway. And if there's any questions that you'd like to ask me, please feel free to fire away.
Thank you very much, Rose. So if you want, you can ask any questions now. You can ask the questions on the live chat. I do have some questions that was sent to me by email to Rose. So the first question was this person that works in blood science, and she wanted to know what kind of skills she need to in order to work in cytopathology, or what can she do to give a little bit of an opportunity to work with us. If you could answer this.
Yes, I can answer that. So, do we know what grade this person is?
She's a band 5.
Right. So we don't know if she's a BMS or an MLA.
BMS.
BMS. Okay. So as long as she's a BMS, to work in cytopathology, as I've said, over 50% of our work involves attending clinics where we've got patient contact. And the skills that we would require there is for a member of staff to show empathy, to be compassionate, to be aware of the situation that can take place in a clinic, because patients, they can either be outpatients or inpatients, and they've already seen the clinician. And when we get called from the department to attend a clinic, we have to understand from a patient's perspective that they've come to a clinic to have a procedure, and all of a sudden another member of staff has entered the room. So it can be quite anxious for the patient. So we've always got to be compassionate and understanding. And all the BMSs, what they do as soon as they enter a room, they always say, "Hello, my name is," introduce themselves and explain to them why they are actually there. And it's always being aware that we always have to put the patient first, and to always explain our role, and to understand and be compassionate towards others. And everyone working within this trust at MFT always puts the trust values in their daily work, which is excellent.
It's absolutely true, Rose, and I can say by experience working with this amazing team that it's actually it can be very emotional sometimes working with patients that not always have good news, but you need to be resilient, compassion. I have another question. So this is how do I get into consultant BMS pathway if you do not have a training officer in the department where you work?
So to become a consultant biomedical scientist, you do need a training officer as well, a consultant that overlooks your work. To do this, your department needs to be registered as a training centre with the IBMS. So that's one of the first things that every department should have, is a registration with the IBMS as an approved training centre. And if the person wants to further their career and become a consultant BMS, they need to have a mentor or a person that shadows their reporting, and it's usually a consultant that does that. So they'd have to approach a consultant within their department to mentor them.
Another question. Is Masters in Biomedical Science an equivalent to expert practitioner qualification?
The MSc in Biomedical Science is the equivalent to the specialist, to the highest specialist portfolio. So staff have two options. Once they've done their specialist in the discipline that they're working in, and that usually takes them to a band 6 at this trust. If they wish to progress to a band 7, it's either an MSc in biomedical science or the highest specialist portfolio, and the two are equivalent to each other.
Mm-hmm. I guess many people have this question because I got the same question on an email. Some MLAs do have a biomedical science degree and do have a master's, and they still feel that they don't have the opportunity to progress because of the registration. I understand that's a huge gap in the biomedical science degree. What's your idea about this, Rose?
Yeah, there is a huge gap in the universities providing the biomedical science degree as a 3-year full-time course. I currently teach at Manchester Metropolitan University for the past few years, and what I have noticed with the undergrad students is that around about year 2 is that when they realise that the degree course that they have started doesn't provide a placement in order for them to complete the registration portfolio, which is a big issue with the universities at the moment. So I'm working with the universities, as you know, Paula, to try and promote a 4-year degree course rather than a 3-year degree course, or if it is 3-year degree course, at the end of each at the end of the summer semester is to try and have a placement at the local hospital so they can start completing their registration portfolio. So the universities ideally need to work with their local NHS trust to provide for their students the registration portfolio. And it's such a shame that when students after completing their A-levels aren't sure of what they really want to do, all they know is that they're good at science, so they then choose to do the biomedical science degree, which is a 3-year course, and only realizing around about year 2 that they would like to work in the NHS, that there is a job as a biomedical scientist. Most students around about 18 are unaware at sixth form college that there is pathology. So it's actually promoting pathology to the younger age groups from 16 to 18-year-olds to explain to them that there are jobs in the hospitals, and part of those jobs are pathology, and in pathology it's lab work, and in lab work you need to become a biomedical scientist, and this is a route that you need. You need to be a registered biomedical scientist in order for you to gain that first job after you've graduated. And the main thing is not having that registration portfolio. So hopefully, as we move forward, we'll be able to communicate that to the students, and hopefully as well the universities, when they're advertising their degrees on their lovely web pages that they have, is to explain to students that these are the possible career pathways. If you choose to go into pathology as a biomedical scientist, you need a registration portfolio, and it is recommended that you try and get a placement. So it's just making students aware and making them try and make informed decisions before they start their university career.
Yeah, totally agree. We have 2 more questions. Oh, I'm sorry. Someone is asking if they have a master's in another qualification, for example, public health or management, if it's equivalent to specialist portfolio.
So what was that, Paul? I didn't get the last part. So they've got a master's in healthcare.
They got a master's in public health or management. They say either, and if it's equivalent to the specialist portfolio.
To my knowledge, the MSc in biomedical science is equivalent to the higher specialist portfolio. However, just to get confirmation, they can always approach the IBMS and ask for their advice.
I believe in this case, unfortunately, the masters won't give you the equivalent, because in my case, it doesn't apply to me, and I'm doing the specialist portfolio. So yeah, ideally will be contact the IBMS.
Yeah.
So the last question for you, Rose, is if I study abroad and I move to the UK, how can I get into diagnostic cytopathology?
Okay, so the same procedure will apply whether you're abroad or whether you're in the UK, is that you have to approach the IBMS and submit your qualifications, and most likely they will contact your university where you did your degree, and ask for the modules, and they will then advise whether you are a biomedical scientist or whether you need to do any top-up qualifications. So the main thing is always approaching the IBMS, asking them for advice, because they are the ones that will approve you for you to then get registered with the Healthcare Professions Council.
Exactly. We have me and another colleague. We're from Spain and Portugal, so it's totally possible to work in the NHS coming from a.
Yeah. Unfortunately, it's whatever the IBMS dictates.
Yeah.
That's the rules. That
I would add as well to contact HCPC, because they might give you a hand with that. Moving on. So thank you very much, Rose. It was a wonderful talk. Thank you. We're moving on with to Dr. Shelton.
Hello, my name's David. I'm a consultant cytopathologist here at Manchester Cytology Centre, and I'm the clinical lead for Diagnostic Cytology. Can everybody hear me okay? Excellent. So today I was just going to talk about basically what does a pathologist do, how do we do it, what's my sort of job like on a day-to-day basis, and then highlight the importance of our working with the BMS team. I'm aware that people on the call are probably at different stages of their careers, so I'm going to keep it very basic. I hope that's okay. But if you have any questions as I'm going along, either raise up your hand emoji or just drop it in the chat, and I can see it as I'm going along. So, what is a pathologist? So, a pathologist is a doctor or a scientist, and we're specialists in the diagnosis of illness and disease. There are, I'm sure you'll all know, there are lots of different branches of pathology, such as biochemistry, microbiology, hematology, immunology, but we are cellular pathologists, so we work in cellular pathology, so that's what I'll concentrate on today. So in cellular pathology, we specialize in the diagnosis and study of diseases by looking at cells and tissue samples under the microscope. That's what we do in a nutshell. So there are three main ways that we help the clinicians. We don't actually look after patients ourselves, although some cytopathologists might attend FNA clinics to perform their own fine needle aspirations or to take their own samples. But in general, we don't have our own patients, so we aid the clinicians, such as Dr. Bailey, in three ways, I would say. The first is the diagnosis of disease. So a patient will come with an illness and we help them come to the diagnosis as to what is wrong with that patient. And we do that by examining tissue samples or biopsies under the microscope. The next way we could aid the clinicians is by providing a prognosis. So we'll provide them with a pathological diagnosis, and then based on the extent of the disease or the type of disease, Dr. Bailey or one of the other clinicians will have an idea how likely is it the patient who is going to recover, or what's going to be the clinical outcome for that patient. And then the third way is that we can help is by helping the clinicians by directing the future treatment of the patient. So, for example, by providing a diagnosis of a certain disease, we might be able to determine that this patient that the disease will be sensitive to a certain type of chemotherapy, or the patient is more likely to have radiotherapy. And going into the future, there's a lot more emphasis on molecular and targeted medicine. So we can provide that service to the clinicians by analysing the samples and identifying whether if the patient has sensitivity to any specific treatments. So those are the three main ways that we would help the clinicians. So how do we do it? So we will receive the sample into the laboratory where it's processed by the BMS team. We will then, the BMS team will process the sample and provide us with slides, which we'll then examine under the microscope. Because the work in pathology is so broad, cellular pathology is divided up into lots of different areas. So you could have pathologists who are specialists in gastrointestinal pathology, doctors who are specialists in cardiothoracic. My specialism and the specialism within the department is cytopathology. So we study disease by examining the morphology of the cells themselves. This area of cellular pathology is particularly vital for cancer diagnosis, so it's an area where this service is utilised primarily. And our department at Manchester is unique in the fact that we're a separate and dedicated cytopathology department. Elsewhere in the country, more often, the cytopathology is performed within the histopathology laboratories. So cellular pathology can be divided into those two broad areas, so histopathology and cytopathology. Again, for people that are earlier on in their careers, histopathology is examination of larger tissue biopsies and resection specimens under the microscope, whereas cytopathology, we have much more limited material. It can be taken by fine needle aspiration or fluid samples, for example, and there are pros and cons to both. So I think the benefits of cytopathology over the histopathology is that it's minimally invasive. We can process the sample rapidly, which can inform real-time clinical decision-making. So an example of this would be within the EBUS clinic and the rapid on-site evaluation, which I think Dr. Bailey might talk about, and where we can guide the clinical decision-making whilst the patient is in the room. Whereas within histopathology, the processing is slower. It can take a day to process the sample, sometimes longer. The benefit of cytopathology over histopathology is also that patients can have the samples taken usually under minimal or no sedation, which has benefits to the patient. Whereas with histopathology, biopsies or excision biopsies, the patients may require general anaesthetic in some situations, which requires theatre space and obviously the clinical expertise to provide that sedation or anaesthetic. There are positives to histopathology over cytopathology as well, conversely. So in general, histopathology is considered the gold standard of diagnosis. And in certain circumstances, diagnosis can only be reached on histopathology. As per the NICE guidance. So areas such as lymphoma diagnosis, for example, histopathology is generally preferred by the clinicians. So on a day-to-day, my work would be mostly diagnostic work on the microscope. So looking down the microscope and writing reports for clinicians. I would be attending multidisciplinary team meetings with clinicians such as Dr. Bailey, radiologists, nursing staff, other allied health professionals, oncologists, where we would meet and discuss the sort of diagnostic workup for the patient and then come to a consensus agreement as to the treatment that the patient should receive. I also attend clinics to provide real-time diagnosis. So, for example, the EBUS clinics with Dr. Bailey, and I think that's vital. The close working relationships with the clinicians is vital. I also work very closely with the Bms teams, with Rose and with Paula, and also with the MLA team to improve our service locally. I'm heavily involved in teaching and training, not only of the BMS staff, but also of junior doctors, trainee pathologists, and other allied health professionals. As a department, we're involved with research, so we'll spend some time doing research projects and audit projects, and also involved with hospital management as the clinical lead. So we have a clinical input into how the hospital is managed. So then moving on to the working with the BMS team, I think this is probably the most important part for the talk, the most relevant to everyone. So I think working closely with the BMS and the clinical teams within the pathology department is really vital. And it's vital because the closer we work together, and the better the relationship we have, the better outcomes the patient will have ultimately at the end of the day, because we all contribute to the final diagnosis and we all contribute to the test. I think so. Areas where we would work closely, I'll give you some examples. So sample triage is a good example. So when we receive a sample from the clinical team, they will be taken into the Cat3 laboratory, and twice a day the consultant pathologists will meet with the biomedical scientists, and we discuss each of the cases, and we'll decide how those cases should be prepared and whether any ancillary testing needs to be done. So, for example, we'll look at the clinical information. If there was a query about lymphoma, we might take some of the sample and we'll send it for flow cytometry. If we look at the sample and there's a query for infection, we might take some of that sample and send it for microbiology. If there is a query of malignancy or a past medical history of malignancy, we might split the sample to prepare a cell block in advance to reduce our turnaround times and increase the likelihood we're going to have sufficient material for immunocytochemistry or for molecular testing. And I think that triage is vital. It certainly does help from a clinical point of view, in that we can ensure we have sufficient material and the right test is done on the right patient. In other areas where we work closely together would be with BMS adequacy provision and the Rose clinics. So our BMS will attend head and neck clinics and radiology clinics and provide adequacy for the clinicians. So we work closely together to train the BMS to provide that adequacy. And then when the BMS come back from the clinics with the sample, we'll discuss it on the multi-header microscope and see if there are any sort of learning opportunities. Within the Rose clinic, so I will be there at the rapid on-site clinics with a BMS, with a member of the BMS team. So the BMS team, the BMS who is there will rapidly stain the sample and I'll examine it under the microscope. So good communication is vital there to ensure that we have quick staining and also, you know, the best staining we can get on the material in the time that we have. Another area I think that is very important and where we work well together is in the case workup. So this is in the pre-analytical phase. So before the case would come to me, a member of the biomedical scientist team will obviously check all of the sample details, check the clinical details, and will also work the case up. So they will search for the radiology reports, so for any clinical letters, any previous histology or pathology results, and basically attach all of that to the case. And so when the case comes through to me, all that information is already available, and that information is vital for correct interpretation of the case, and it also helps our turnaround times. That information is already there. Our CBMS, our consultant BMS, will not only report exfoliative cytology, but they will also attend rapid on-site clinics and provide adequacy, and they'll also attend the MDT meetings on behalf of the department and help make those clinical decisions. Us pathologists are heavily reliant on the BMS team for the sample quality. If we have poorly prepared samples, we're going to issue poor results. So that is really vital, and the communication between the BMS team and the consultants, is really important to ensure we're getting the best quality preparations. We're also reliant on them in the operational side of running the lab. I have to say that Rose and the rest of the BMS team do an excellent job of managing all of the operational issues. So a question just popped up regarding the Rose clinics. Can I ask if you use both MGG and PAP staining? So at the Rose clinics, we have a rapid diff stain. So we prepare for each pass, we prepare one air dried spread, which then we'll do a rapid diff stain. So we don't do PAP stains. And Rose has just answered. So that I would say that's coming to the end of the talk. I think good team working, and I think something that's going to be coming out of the NHS in the next year or two is civility and working well together, good team working. And I would highly recommend, if you do work in the NHS, please visit. There's a website. It's just called civilitySavesLives.com. I can put it up in the chat. Go away and have a look at this to see the importance of good team working and good inter-team relationship, how it's so important. I won't go into it in too much detail now, but I would, highly recommend going away and have a read of it. There's a TED Talk associated with that. If you have chance, have a look at the TED Talk. Thanks very much. Do you have any more questions?
Thank you so much, David. Thank you. And you mentioned something incredible. Yes, BMS consultant, MLA, everyone in diagnostic cytopathology, they do have a kind of special bond, and it's quite an incredible team to work with. And if you would describe in one word how it is to work with everyone, how would you describe?
That's a.
You can use 2 or 3 words.
I think we spend most of our, we spend most of our time working together. I think it's very important that we have a really good relationship, and I'd say that we have the BMS, the consultants, and the MLAs. They have an excellent relationship, and our good, as Rose mentioned, our clinical outcomes are excellent, and that is just testimony of our good working relationships, I would say, and the parts that we play. Each of us plays a part in providing those excellent clinical outcomes. So that's more than 2 words, Paula.
It's excellent. Another thing, so you mentioned that BMS are very involved with the diagnose and with the getting all the radiology. So it needs a lot of information, and it needs a lot of knowledge. So it's not the normal lab work. So how do you develop a BMS to get to your standards of quality?
Yeah, it's a good question. So, and I think a couple of questions have popped up in there. Do your BMS staff pre-report the cytology or pre-screen the cytology? And I think that's sort of linked into it. So I would say, it's a gradual process, and it is reliant to some extent on the pathologists being engaged with the BMS team. And I do sympathise with other departments where the consultants may not hold cytopathology as such a the cytopathology portion of their service may not be as developed as we are. So I would say you need good engagement from the cytopathologist first of all. I think pre-screening the cases is helpful, and that will pre-screening the cases and then discussing those with the pathologist is what I would sort of suggest. And I know we do that to some extent with the adequacy and with the IQC here at Manchester Cytology Centre. I think attending MDTs where possible. So the consultant BMS will attend MDTs, but I would encourage, if possible, other BMS, maybe not every week, but to attend MDTs to see how our report will influence the clinical decision making. And then obviously going through your BMS training pathways, you will be developing your clinical expertise that way also.
Yes, David, there's also a question regarding Rose from Jennifer Kershaw. I think she works at Pennine. So her question is regarding Rose clinic. She'd like to ask if both MGG and PAP staining are used. So what we do at Anibus Rose clinic is that we make spreads, and we'll do a RAPD stain at the clinic, where the consultant cytopathologist will then give a rapid on-site evaluation. When we come back to the lab, the material that we flushed into the cytorich red at the clinic, a LBC SurePath slide is made from that. So that's to answer that question. So we're using rapid staining at the clinic, and the residual material that's flushed into the cytorich red from the needle rinse is made into an LBC PAP slide.
Rose, I have another question for you from immunology. To get a higher specialist, how much experience do you require as a Band 6?
They recommend that you have at least 2 years experience before you move on to the higher specialist.
Okay. Thank you very much. Thank you, David.
Yeah, thank you, David. There's also a question regarding from Tracy Stevenson. Do all of your BMS staff pre-report the cytology? So it's only the BMS staff, we do the internal quality control, where we're looking at the technical quality of the slide, and that's looking at the staining of the slide. But also, it's not a prerequisite that we're pre-screening the slides, but the BMS do, as a CPD, do look at the actual slides, and especially if they've attended the FNA for that patient. So they've seen the sample being taken, they've prepared the sample, and then they've actually had a look at the cells that have come from that patient.
Another question for experience regarding Band 5. How much experience do you need before specialist portfolio to start?
Ideally, once you've done your registration portfolio and then you move on to your specialist portfolio, you would like to have at least a year's experience where you're competent in doing the roles that you've been employed to do, and then you can apply for your specialist. But however, if you've been in the department prior to doing your registration portfolio, you may not need a year's experience. You could do it earlier, but it's recommended that usually after your registration you become competent in the role that you're doing, and then to do your specialist portfolio after that.
This is for David Shelton. As a consultant BMS, do you still get to attend EVAs or on-site clinics, or this will be mainly reporting? It can be for either.
So yeah, so our consultant BMS does attend EBUS clinics. So she will do a mixture of both attending EBUS clinics and reporting.
Okay, thank you very much, David. Thank you, Rose. Simon, thank you very much for joining us. I know you're very busy. Well, so the word is yours.
Yeah, no problem. So I'm Simon Bailey, a respiratory physician working at Manchester Royal, working closely with David and the cytopathology team and the BMSs. So I guess just probably not got that long, so I'll go as quickly as I can and really just talk about what I do on a daily basis. So I'm the lung cancer lead here at Manchester Royal. And so my job really is to get people through that pathway as quickly as possible. And certainly speed is of the issue really, and has become more of the issue recently, because we know that lung cancer patients can deteriorate very quickly, and their performance status can deteriorate quickly. So we need a diagnosis and a stage for that lung cancer extremely quickly. And we've got a national optimal lung cancer pathway. So ideally, what the government's saying is that we need a diagnosis days of referral. Internally within Greater Manchester, we think that's probably still too long. So we're looking at 14 days. So you're talking about getting people through pathways extremely quickly. And cytopathology dovetails in that extremely well. So if we get a referral from a GP with a query lung cancer and it turns out maybe on a chest x-ray, so we'll get them a rapid CT. It is going to be every single day, Monday to Friday. At the moment, it's Monday, Wednesday and Friday. And then once they've had the CT, we'll get that reported on the day. And then we need to make a decision. Is it lung cancer? If it's not, then we can let the patient know very quickly. If it is, then we need to make a decision. Does it look like it's radically treatable, or is it extensive lung cancer? And if it's extensive lung cancer, then what we need is tissue. And tissue will help us to decide what type of lung cancer it is, and also what would be the treatment. As David mentioned, cytopathology helps us to decide what specific treatments, and there's a lot more individualized treatments coming through. So we really do need quite a precise diagnosis in people with extensive disease. It's relatively easy for us after the CT, because what we need then is tissue, and then to pass that patient on, if they're fit enough, to a oncologist. So we've got some really good relationships in the fact that we'll get the CT on the day. Before COVID, the patient will be in the clinic with us, giving the results, and it may be that shows extensive disease, but maybe a lymph node in the neck, or a pleural effusion, or even a metastasis in the skin. So what we would do in that situation is we'd phone up the BMS, Certainly if it was a neck node or a skin metastasis, and within the clinic, we'd obviously explain to the patient with the lung cancer specialist nurses what we were going to do. A BMS would come down, and then we would usually, with a very fine needle, not even use any local anaesthetic. As David was mentioning, cytopathology is very small samples and very small needles. So we do with ultrasound in the neck, not, with no anaesthetic, we would do maybe 3 or 4 passes with an extremely small needle. We'd hand that to the BMS. They would prepare the samples, and as they're preparing it, we would do a second pass. And we'd do that relatively quickly, and then that would go back to the lab. And then we'd probably get a phone call the same day from either David or one of his colleagues telling us what, has it been a successful in giving us the diagnosis, and what is the diagnosis. And sometimes they can tell us what the diagnosis is if it's small cell, and that makes a huge difference. And certainly, so what can happen is the patient can have a CT, can have a diagnostic procedure, and possibly even a diagnosis on the same day. And so the pathway is really, really short, and then we'll wait for other tests to come through. But if it's small cell, we might even refer that patient on the same day to an oncologist. So the actual speed that cytopathology gives us is absolutely incredible. So that's kind of, and if we're on the wards, the other thing which cytopathology do is with pleural effusion. So if somebody comes in and they're an inpatient and they've got a pleural effusion, sometimes they're very breathless, so we have to put a drain in. And what we need to do is think, how do we treat that patient to prevent the fluid coming back? And we need a diagnosis. So if we can get a diagnosis from the fluid, what we can then do is put what we call talcum powder down the drain, and to try and stick the layers of the outside of the lung to the inside of the chest wall, stop it coming back. But we need a diagnosis to do that. And certainly cytopathology are very good at giving us that. Here at MRI, as David mentioned, there are specific cytopathology departments. So the actual quality of the results we get back from our very small samples are very different to what my colleagues will get back in other hospitals, where you've got a histopathology department looking at cytopathology specimens. And that's not a criticism, that's just to say that these guys are specialists in their field of cytopathology, and it makes a huge difference to a clinician at the end getting those results. From a BMS point of view, because I know most of you guys are BMSs, then having that interaction with the BMS is really important. And they're extremely helpful when the patient's there. They come down, they're very nice, and they interact with the patient very well. They're very courteous, and they prepare the samples absolutely perfectly. They have extra needles if we need them, extra kit if we need them. They come down with a little handheld box, and they're just very, very good. And because we deal with them on such a regular occasion, we've built up a really good relationship. People like Rose and Paula and her colleagues, because we know them very well, and they come, whenever we need them, they're there. And whether that's the ward or whether that's in a more specialised area like the rapid on-site evaluation that we do at EBUS, I mean, that is a really, really specialised service, and makes a huge difference to patients. And I guess certainly with the ROSE, the rapid on-site evaluation, again, we've often given patients diagnoses after their EBUS procedure, still in the endoscopy department with the lung cancer specialist nurses when it's small cell, because when people have got small cell lung cancer, it can often be diagnosed on morphology by David and his colleagues, and therefore we can tell the patient what we're dealing with, refer on the same day, and then they'll see the oncologist very quickly, because small cell is a rapid condition that can worsen very quickly. I guess I'll just give you one particular personal example. So a couple of weeks ago, an 88-year-old chap came in after a fall, had an extremely abnormal chest x-ray, therefore went on to have a CT scan, and on the same day, so that was said to be mesothelioma, which is a cancer. This was from the CT scan, a cancer which is associated with asbestos. And this chap, I think, was an electrician, so he's had some asbestos exposure. He wasn't a good performance status, but he still needed to know what was going on. And he did have a neck node. So I phoned the BMSs, they came down. He was quite poorly at the time, and actually putting him through a biopsy would have been very difficult for this chap to tolerate, and certainly a bronchoscopy or an EBUS, he wouldn't tolerate that. So I had a good chat with him, and I said, you know, we can find out more by taking a sample. He was happy with that. We did that with absolutely no problem at all, because the needles are so small, and he tolerated that. And it actually wasn't mesothelioma like the radiologist had said, it was small cell lung cancer. So they gave us a diagnosis. We could tell him, we could tell his family, they could plan. It was nothing to do with asbestos. We didn't need to involve the coroner. So it made a huge difference. That very, very simple test in his neck with an ultrasound didn't cause him any discomfort, and we got the diagnosis very, very quickly. So the actual interaction between ourselves, the BMSs and the cytopathologists, make a huge difference. If you do a biopsy, it goes to histopathology, and it takes a long time to come back. And it's a totally different experience with cytopathology. There are drawbacks. There are certainly drawbacks, and certainly certain specific conditions such as lymphoma often does need histology. But the majority of things, certainly with lung cancer, which is what I deal with, can be done with cytopathology, and we're very heavily cytopathology dependent, certainly in particular in our hospital. So I'd certainly say that the service is very good, and our interactions with the BMSs are very good. So I've got nothing but praise for the department. They certainly keep us in line, and they're very organised, and certainly we heavily rely on them at various areas such as the MDT. And they give us, we often, certainly just to go back to the EBUS lists, they often ask us questions. That we often interact with David and his colleagues beforehand, and we think we're going to do one thing, but they've got a little bit of information as well, so they often direct us in a different way, which helps the patients massively. So certainly open to any questions, but I would say if you were thinking about being a BMS, be a BMS at MRI, because it's a great place to work for cytopathology and BMS. Back to you, Paula.
Thank you so much, Simon. That was so insightful, and very kind words. Thank you so much. Everyone will appreciate, and the colleagues that couldn't, unfortunately, they were working, they couldn't attend. I'll pass your words to them. I have a question for you. You gave an excellent example of how cytology could help with the patient, giving your patient's example. Regarding the mental health of any patient with cancer, how do you think the cytology will help? Because certainly stress is a very difficult for a lot of patients with cancer, something to manage. So how do you think it helps?
Yeah, so I guess, I mean, psychologically, it certainly helps to know. We often say this is 100%. Because sometimes it is very difficult to deal with uncertainty, and sometimes things are uncertain. Whereas if you can get a cytological diagnosis, we often say this is, it's 100% we're certain this is cancer. There's no doubt about it. Whereas with a scan, it is just a scan. So sometimes it's difficult, and certainly having a definitive diagnosis can help a hell of a lot, and people can deal with things. Certainty is a lot better than having that uncertainty. And certainly in the diagnostic pathway, if people are going for radical treatment, so if they're going for surgery, the surgeons tell us it's often a hell of a lot easier if we have a diagnosis beforehand, because some patients don't have a diagnosis. We're assuming it's lung cancer and they go for surgery. So they're going for a surgical procedure when they're not sure 100% if this is cancer. If you can get that diagnosis beforehand, again, that can help the patient themselves, can help the consent process, because we know what we're dealing with. So that's the difference really between radiology and cytopathology or pathology, is that that's really the definitive answer. And I showed in my example that what the radiologists think is one thing can often be different once we get pathology. So certainty is a big thing.
Thank you very much. I think anyone wants to ask any questions to Simon? I have a question I think is more for David. Do you carry out molecular analysis on site, or is sent to a specialist center for?
Oh,
So,
sorry.
yeah.
Sorry, Dave. I've just answered that. We have the Regional Genetics Centre on site at Oxford Road.
I have a question for Simon. Have you noticed an increase of presentation of cancer during the pandemic?
So yes, now the pandemic's sort of kind of finishing and over, we've had I think an increase in a lot more advanced cancers, actually, a lot more inpatients. And during the actual pandemic itself, we had a drop, probably 50% drop in lung cancer referrals and a 50% drop in diagnoses. But now we are seeing more and more advanced disease. Yeah, definitely.
Thank you. Last question for you. What do you think is the future of collaboration between lung cancer centers and cytology?
Yeah, I think it's going to be more and more because I think just because it's the cytopathology is a lot easier to get than histology, and the interaction has to be a lot more because we're having to do more and more with less and less. So I think having a Rose service, which is often what we'll do is when we know the diagnosis, we'll be asked by David and his colleagues to get more passes. And it's often very good to know you've hit the spot with Rose and then you do more passes because, next generation sequencing, knowing a lot more about the tumour and having a lot more treatments available and individual treatments available. So I think that interaction between the clinicians and BMS and cytopathology is going to be a lot more, really, because we are going to be wanting more and more on these small samples. So I think it's going to increase, and I think it's going to expand. Basically, I think cytopathology expand more and more.
Thank you, Simon. I think this question goes for David, but it's quite related to the ones that Simon was answering. So do you see cytology playing a key role in genomic medicine and research?
So I would agree with Simon. It definitely play a role. It's very easy it's much easier to obtain the cytology samples versus the histology samples. I think also we have, although we might not have as much material as they would potentially in a biopsy, the way that we process the sample is much sort of kinder to the genomic process, to the processing that is required for the genomic. So formalin fixation, for example, will hinder some of the genomic processing, whereas we fix our samples in Triage. And the DNA is much easier to extract. So I think we definitely, I think definitely we will see cytology playing a bigger role going forward. And I agree. So, and I see a question just come up to expand on the question from fresh material straight to genomics. So I think that's where we will definitely play a role also. As Simon says, we'll be there at the EBUS clinic. We will be able to provide a rapid on-site diagnosis of cancer. An additional pass could then be taken, which could go fresh to straight to genomics. So I agree. I think that will be the way forward with cytology. We're already with our EBUS samples. We're already doing next generation sequencing now as routine on our samples. So I think that's excellent. And as the technology improves, we will only get better, I think, in cytology. Shall I answer the one? Do you see slide processing to be more automated, or is more
yes,
with?
you do. Or
maybe Rose actually. I think is that to do with processing the samples rather than interpreting. Maybe for Rose.
Yeah. So slide processing currently, all we're using automation for is the PAP staining, and it's the Totalis slide prep machine from BD. All other work is done manually by the BMS, and that will continue. Just to answer the question on if histology is done on EBA specimen, is it done on the rapid processor? No, it's not done on the rapid processor. Most of the EBA samples that we receive have clots present. So we extract the clots at the clinic, place them into formalin, and then they'll go on the overnight histology processor. We did try to validate the rapid short processor in histology, but that didn't work, so we're sticking to the overnight processor. And just to answer the question from Anastasia, how many cytology cases do we have a year? So it's approximately around about 4,000 samples we have each year.
So unfortunately, our time is over. I want to thank you, everyone, to our guests, Simon, Rose, and Debbie. Thank you so much. It was an amazing talk. And to everyone that attended, if you have any questions, you can leave on our chat and we'll try to answer. And everyone that register on our Eventbrite, they will get some resources and they will get this video so you can watch later. This is CPD accredited, so you can do your reflective practice and add to your CPD on IBMS. I would also like to thank our sponsor, that's IBMS, and I hope we can join you. You can join us if you're working at MFT in our game in the afternoon. If not, maybe next year. Well, I hope we'll have another amazing webinar. Thank you so much.
Thank you, Paula.
Thank you, Paula.
Goodbye. Thank you.